All right. Hi, everyone. Thanks for joining us this afternoon for our webinar on opportunities to improve maternal and child home visiting for Medicaid and maternal, infant, and early child home visiting. Improving maternal health has been and remains a priority for the Biden-Harris administration. And through this effort, CMS and states have prioritized ensuring comprehensive coverage for maternal health, including 12 months of Medicaid postpartum coverage, now approved in 45 states. We also want to give a big thank you to the advocate organizations with the National Home Visiting Coalition, looking to improve and expand these services. The Center for Medicaid and CHIP Services and the Health Resources and Services Administration have been working collaboratively to inform states about resources available to help them meet the needs of pregnant women and families with young children, specifically with respect to home visiting services. And we hope to provide some more guidance and showcase a few states that are doing this in various ways. So the presentation will be followed by a Q&A where you can drop your questions in the Q&A chat for either the CMCS and HRSA folks or for our state colleagues. We ask that you refrain from putting questions in the chat until we reach the Q&A portion of the webinar. And we have presenting with us Cindy Phillips from HRSA, Kate Guinness from CMCS, Kate Wilcox and Pamela Ferguson from Oregon Medicaid, Alana Dancis from New Mexico Medicaid, and Travis Hauser from Alabama Medicaid. So with all that, I'll pass it off to Cindy to get us started.
Thanks so much, Nina. And it's so great. This is amazing as I'm watching everybody come on. We are very excited to have you all here. I'm Cindy Phillips. I'm the director of the Division of Home Visiting and Early Childhood Systems within the Maternal and Child Health Bureau at HRSA. For those of you who are not familiar with home visiting, it's a service delivery strategy that aims to support the healthy development and well-being of children and families. The Maternal, Infant, and Early Childhood Home Visiting Program, which we'll refer to as MIECHV, supports home visiting for expectant and new parents with children up to kindergarten entry who live in communities that are at risk for poor maternal and child health outcomes. The MIECHV program is administered by HRSA in partnership for the Administration for Children and Families. And the MIECHV program provides funds to states, jurisdictions, and tribal communities to implement evidence-based home visiting services. One facet of the program is that it is voluntary. Families choose to participate in home visiting programs. And home visitors partner with health, social service, and child development professionals to set and achieve goals that improve their health and well-being. Home visitors work with pregnant people to access prenatal care and engage in healthy behaviors during and after pregnancy. Home visitors also often provide screening, education, service referrals, and care coordination to address key maternal health risk factors. And these include postpartum depression, intimate partner violence, and tobacco use. Home visitors conduct child development screening and refer children and families to services if a delay or concern is identified. Home visitors also partner with families to connect children to recommended well visits that support child health. And home visitors help parents set goals to promote their financial self-sufficiency. Nina, next slide. So as you can see here, there are many benefits of home visiting. The home visiting field has been engaged in research and evaluation for decades, generating a rich literature on the effects of home visiting. Studies have found that home visits by a nurse, a social worker, and early childhood educator during pregnancy and in the first years of life improve various maternal, child, and family health outcomes. Home visiting programs promote positive parenting practices that help support safe, stable, and nurturing environments. This two-generation approach of early childhood home visiting has been shown to be effective in multiple domains, as you can see from this slide. For example, parents enrolled in home visiting programs are more likely to have a safe play environment at home for their children, provide age-appropriate books, and engage children in structured teaching activities. Home visiting programs have demonstrated long-term positive impact on children's development and academic achievement. Home visiting programs are associated with reduced rates of child maltreatment and injuries. And compared to their counterparts, parents enrolled in home visiting have higher monthly incomes and are more likely to be enrolled in school and are more likely to be employed. Evidence-based early childhood home visiting appears also to be effective, cost-effective in the long run, with the largest benefits being reduced spending on government programs, reduced need for public assistance, and increases in individual earnings. Government savings have stemmed from reductions in child abuse and neglect, reduction in the use of special education services, and reduction in crime. In addition, home visiting reduces disparities in maternal and child health outcomes by addressing social and community factors that can negatively impact a family's well-being. Next slide. In fiscal year 2023, the MIECHV program has served nearly 140 parents and children in 69,000 families and provided over 919,000 home visits across the US. The program was reauthorized in December of 2022 for an additional 5 years. The reauthorization provides an opportunity to expand evidence-based home visiting services across the nation. Through reauthorization, the program was appropriated $500 million in fiscal year 23, with expansion to $800 million by 2027, for a total of $3.1 billion over 5 years. Beginning this year, HHS is making available an additional $40 million in MIECHV matching grant funds available to states and jurisdictions to both enhance and expand home visiting services. For the first time ever, states and jurisdictions can apply for federal matching grants, which allows them to receive $3 in federal funds for every dollar they matched based on availability of funding. This is the first expansion of the program in over 10 years, and it allows for the doubling of the program, reaching even more communities and more families who can benefit from services. So thank you, and I'm going to turn it over to Kate Guinness.
Thanks, Cindy. So I am delighted to be here. I'm Kate Guinness. I'm a senior policy advisor for all things kids at the Center for Medicaid and CHIP Services. I'm guessing that folks who are here are familiar with that, but Medicaid and CHIP cover about a little bit over 41 million kids in the country, which is almost half of the kids in the country, and covers a broad range of health services and really the most comprehensive care for kids is found under the Medicaid Authority. And so I'm very excited to be talking about the intersection and to have some of our states here talking about the intersection of Medicaid and MIECHV. The other thing that sort of the intersection here is about 40% of the births in the country are covered by Medicaid. And there are some really the Biden-Harris administration has made some enormous strides and helped states to make enormous strides in the coverage for kids, including the coverage for the 1-year postpartum coverage in 45 states, requiring 12-month continuous eligibility within Medicaid for kids, and really recognizing that these coverage, the coverage enables kids, and especially we're talking about the youngest families, to get services that they need to support the growth and well-being of the children and the parent-child dyad. If you work in Medicaid or with Medicaid at all, you have heard the expression, if you've met one state Medicaid program, you've met one state Medicaid program. So I'm going to talk about some of the possible things that states can do. And then really the focus of today is to hear from 3 states and the different approaches that they have taken to broaden the coverage of their home visiting programs by using different Medicaid authorities. So I'm very excited to have our state colleagues here. So I'm not going to go through each of these authorities, but really we put them all on the page so that you can see that there is really a broad range of ways that states could seek to cover the components of home visiting services. And that it actually could go through the child's benefit, through the parent's benefit, the mom's benefit, or in a different pieces of it might be covered under the child and different pieces of it might be covered under the parent. And there might be changes in terms of the child's development, what the services are necessary or the ones that are being utilized. And so it really is, from a Medicaid perspective, there's lots of opportunity here. And there's opportunity to think about covering the whole service, as well as common components of home visiting, like screening, case management, and counseling, which are services that are commonly covered already under Medicaid state plans in many states. Next slide, please. So the current landscape of coverage for home visiting is that every state covers MIECHV, has MIECHV funded home visiting. Not all states have use Medicaid to further that coverage. And really the goal of today's discussion is for you all to hear about some ways that some states have used Medicaid reimbursement pathways to increase access to home visiting for young families. And there's a lot of, we hear a lot about wanting to know how to braid funding. And so what you'll hear is 3 different states who are using different authorities to have, it's very important that the funding, it be very clear where the funding is coming from and how, especially with federal funding, making sure that things are not getting paid for twice, for instance. And so you'll hear from states about how they are taking their particular approaches and making sure that they can get more services to young families while also ensuring that the authorities are clear and the funding is clear. So I think with that, I am going to pass it off to my colleague, Travis Hauser in Alabama, who's going to tell us about their approach, I think, using targeted case management. Travis?
Thank you, Kate. Good afternoon, everybody. My name is Travis Hauser. I am the Health Systems Director for the Department of Health Systems at the Alabama Medicaid Agency. And today I will give an overview of our Nurse Family Partnership Program. Next slide. First, I would like to give an overview of maternal and infant health in Alabama. Our top issues is, number one, we're the 5th highest in the nation in regards to infant mortality. We're the 2nd highest in the nation in regards to preterm birth rates. We have a birth weight of about 61 per 1,000 women ages 15 to 44 and rank 14 in the nation. And we have the 5th highest teen pregnancy rate in the nation. Those are alarming concerns from us. So some of the ways that we are addressing some of these issues is through our PCCME, which is our Alabama Coordinated Health Network. That is a statewide care coordination system. We did extend our postpartum coverage from 60 days to 12 months. That was effective on October 1st of 2022. We also extended dental coverage to our pregnant recipient through the 60th day postpartum, and that also went into effect on October 1st of 2022. We implemented the Nurse Family Partnership Program as a target case management model that went into effect on January 1st of 2022. And we are anticipating applying for the Transforming Maternal Health Grant that is currently due on September 20th. Next slide. So what is NFP? NFP is an evidence-based community health program with over 40 years of evidence showing significant improvements in the health and lives of first-time moms and their children living in poverty. The vision is a future where all children are healthy, families thrive, communities prosper, and a cycle of poverty is broken. The goals is to improve pregnancy outcomes, improve child health and development, and improve economic self-sufficiency for the family. Next slide. NFP has a long track record of consistent and substantial maternal outcome improvements. The Specific Institute of Research and Evaluation predicts that when NFP achieves scales in Alabama, it can produce the following outcomes. That's a 25% decrease in smoking during pregnancy, 33% decrease in maternal hypertension, 25% decrease in closely spaced birth, 15% decrease in first preterm births, 48% decrease in infant mortality, 34% decrease in ED utilization, emergency department, 10% decrease in Medicaid expenditures, 14% improvement in fully vaccinated, and a 12% increase in breastfeeding. By the numbers, the Nurse Family Partnership Program in Alabama, currently we have 3 providers named AlaHealth, the University of Alabama at Birmingham, Gift of Life. Those 3 providers are currently enrolled as Medicaid providers and receive reimbursement through Medicaid. There is a 4th provider in Alabama, Easter Seals. However, they are not currently enrolled with Medicaid, but they can see some of our recipients. As of today, we're not statewide. NFP is covered for the 28 of the 67 counties in Alabama. However, we do expect to expand statewide by 2032. Currently, there are a total of 1,270 recipients. That includes both moms and babies. And then this is just a link to where you can find more information about our enrollment and certification requirement for the NFP program through Alabama Medicaid. Next slide. So Alabama's NFP program. So NFP has been offered in Alabama since 2008 through a grant through the Department of Early Childhood Education. At the time, there were only 9 counties covered for NFP services under that grant. However, when Medicaid began reimbursement on January 1st of 2022, that county increased to 23. And as of today, we have grown to 28 counties. So we're growing and we expect to eventually go statewide by 2032. Next slide. NFP services in Alabama are reimbursed once per month per participating family unit. What that means, if mom and child are seen in the same month, we're only going to pay them one time per month. We decided to take the TCM route for our NFP model. And so providers in our state are enrolled as TCM provider types. They also have to be certified through the National Service Organization, or NSO. And they are expected to follow TCM policy along with NSO policy. We also require that our NFP providers collaborate with our ACHN, which is our PCCME that I mentioned earlier. And so therefore, a referral from the ACHN is required for NFP services. Next slide. So Alabama's NFP program as a TCM model. We recognize NFP recipients in target group 5, which is pregnant women. And when these recipients receive services through the TCM model, they get care coordination, assessment and screenings, case management, and preventive health education and counseling services. Below are the 6 core elements of our TCM programs and are provided when our recipients are enrolled in NFP. There is a needs assessment, there's case planning, there's service arrangement, social support, reassessment and follow-up, and we do ongoing monitoring. Next slide. How our NFP program is funded. Alabama funds its NFP program through the general fund. NFP providers, again, are reimbursed 1 rate per family unit per month. Some providers, I've been told, still utilize MIECHV funds to assist non-Medicaid recipients, such as non-citizens, and to also assist with nurses' salaries. Next slide. Our experience with NFP, Alabama Medicaid, we're fairly new. We're just under over 2 years of implementing NFP in the state. We just completed our first round of clinical audits in which we basically do a medical documentation review to ensure that the providers are doing what we're expected them to do. Some of the things that we found during our internal audit and when speaking with the NFP providers, they do wish to have more virtual visits in the model. They would like us to align our policy more on the side of NSO to prevent duplicate documentation. And they would also like us to research what some of the other states are doing. And so we have taken all of that into consideration to hopefully make our NFP program even better. Next slide. Just contact information if you have any questions or concerns about our NFP program in Alabama. You can contact myself with the email that's displayed on the screen, and Miss Wendy Williams, who's our nurse, and she's the program manager for the NFP program, and her email is displayed as well.
Thank you so much. I think we're now going to be transitioning to our folks with New Mexico.
Can you see me? And here, yep, here we go. Okay, hi. So I'm Alana Dancis. I am the Chief Medical Officer of the Medicaid program in New Mexico, and talk to you a little bit about our Medicaid home visiting program. Next slide. This is a slide we always start with our presentations with, but I'm going to take this opportunity to explain a little bit how our program's set up, because I think, you know, as we said, if you've seen one Medicaid program, you've seen one Medicaid program. And I think it explains a little bit about how we have things set up for the Medicaid home visiting. So Medicaid sits within the Healthcare Authority. We became a Healthcare Authority in July. We used to be the Human Services Department. And so all of the safety net services like SNAP and assistance with heating and assistance with child support, things like that, all live in this department. And then we moved over some other health related departments from Department of Health in July. So within Medicaid, we are primarily a managed care state. We have 4 managed care organizations, and we have a fully integrated managed care program. So every managed care organization has to cover all counties, all services, physical health, behavioral health, and long-term services, and also has quite a few responsibilities as far as social drivers of health that is driven by our 1115 waiver. So, you know, kind of the 2 primary documents that run our program are our managed care contracts and then our 1115 waiver. And our 1115 waiver was written with a population health slant. We have a vision, and then we have 3 goals. Our goals are to do whole person care, thinking about behavioral health, physical health, social drivers all together, to think about new ways of payment that support value. And then our third goal is to target populations that have been historically and intentionally left behind, disenfranchised. So we picked 5 target populations based on places that we fall behind as far as national averages. And maternal child health is one of those target populations. And then we have a number of interventions related to maternal and child health. Okay, you can go to the next slide. So just a little bit of background of our program, our Medicaid home visiting. So I started in 2022. So some of this is kind of coming from talking to other people about the history of it. But we started with a pilot for Medicaid home visiting in our 1115 waiver in January 2019. And at that time, we had 2 models and 2 providers. So we, UNM and I believe MECA. So University of New Mexico Hospital did both models, and then MECA only did parents as teachers. So kind of what I anticipate was the rationale behind this. Nurse Family Partnership has very, very strong outcomes. We were very interested in being part of that. We have a significant nurse shortage in New Mexico. We're about 6,500 nurses short of what we're supposed to be by standards. So including programs that require nurses, it puts a lot of strain, and we got a lot of pushback about that. So, and then in 2020, we did an 1115 waiver amendment where any county and any provider could join. Also in our history, New Mexico Medicaid has never implemented the program. We've always been the payer and are collaborating with another department to implement it. Originally, we were collaborating with Child, Youth, Families Department. So that's our Child Protective Service agency. When this administration, the Lujan Grisham administration, started, early on, an early childhood education care department was started, and Medicaid home visiting moved under ECECD. So now ECECD implements and we pay, and we have kind of a collaborative relationship there. Our next step, what we're working on now, we just started. They were supposed to line up, but because of kind of like some delays on the 1115 waiver side, there was actually delays on both sides. So our new managed care contracts and our 1115 waiver both started in July. So it's called Turquoise Care now, used to be called Centennial Care. And part of our new program is that we added 4 additional home visiting models. Some of these are being paid for through ECECD funding currently. And the plan is that they'll move over to Medicaid home visiting once we are fully up and running. We're still kind of making rates and provider types, et cetera. These are the 4 models that we are adding. And ECECD's vision for the state is a full state kind of comprehensive home visiting system where every single pregnant individual is eligible for some services that could be from light touch to very intense, depending on, the complexity of the member. So, some of these models are for infants and parents who are at risk of maltreatment. Family Connects, the goal will be that will be offered to every single new parent eventually. It's a 1 to 3 visit model. And then if they find that family needs more services, they'll refer on. But all of that is kind of still getting started. There's only one Family Connects provider right now. It's Department of Health, and they're only in 1 site in Albuquerque. But so we're kind of putting the building blocks into place on the Medicaid side for when ECECD is ready to launch those things. Okay, next slide. So this slide is about some of the challenges that we've experienced. And then the next slide, I'll talk about some of the interventions we've had to try to address those challenges. So this is kind of in general, you know, I'm in an administration right now that is rapidly expanding services. After a period of contraction, this administration is more Medicaid, more services, more eligibility types. It's a really exciting place to be, but keeping up with the pace from a staffing and a policy perspective has been really challenging. And so, going from a pilot to a full state multi-model implementation in 5 years has just been a bear. So that's kind of one of our main challenges is just keeping up with all of these new things that are being asked of us. Second, this implementation and collaborate. So this is just kind of an ongoing challenge. It's not just with Medicaid home visiting, but when one department implements and one department pays, which, you know, we pay contract with Department of Health, we contract with Child, Youth, and Family, we contract with aging for the adult daycares. Like we do this a lot where we pay for a service that someone else implements. But Medicaid is such a unique beast, and it's so long to get from the beginning to the end of a new policy. And the socialization, education, communication with other departments about what's going to be involved in accessing these federal dollars and drawing down federal funding, there's just been bumps along the way. And so kind of setting the expectations from the beginning of how long it takes to have an 1115 waiver approved, you know, how long it takes to just kind of operationalize a new benefit, what kinds of evaluation is going to be required. All of those things just between departments has been a challenge. Another big pivot was that most of these providers were used to being paid monthly, and our model is claims. So they get paid per visit, and they're not used to that. And they're also used to having money on the front end in a grant form, not later after they've delivered the service. And so that has been challenging, even with not a lot of denied claims. Just learning to have that kind of pace with funding also required quite a bit of socializing and onboarding. There are also just the number of steps to be onboarded with Medicaid. You know, there's enrollment, there's credentialing, there's contracting, and we've found that the providers need just a high touch type of approach. So that's been another piece. As far as the funding, it is full Medicaid funding. There's not any like overlap rated funding anymore. The only funding that comes from ECECD is onboarding. So they get, and that comes from a state grant, like state funding. So the only in ECECD, they are mandating that all providers in the state move to a Medicaid home visiting model. So they're all kind of starting to switch over. Next challenge has been managed care. The way that the program was set up before I came on was put a lot of pressure on referrals from managed care to agencies. And so that needed to come with some requirements to manage care and some expectations and some reporting, because it just really wasn't happening. And that provider agencies were having trouble kind of advertising and advocating for themselves too. They just really, the uptake wasn't what we wanted it to be at the beginning. And so rates is also complicated because, moving from a monthly to claims has been a little bit of a challenge. Also, as far as home V models, we have a homegrown model called Firstborn that is very widely used in the state and is not a home V model. So kind of working on trying to get that model, some evidence and some studies also moving some provider types out of that model to Medicaid home visiting model so that they can be reimbursed through this has been another piece that we've been navigating. And just kind of like giving all of these to you as you start to think through it, things to think about from the front end. And then just the last one is that we called it Centennial Home Visiting, which was the name of our last program, and our program's called Turquoise Care now. So we changed it to Medicaid Home Visiting, so we don't have to change it every 5 years with CMS. Okay, next slide. So these are some of the things we've been trying to do to improve with some of those challenges that I was talking about. We started this new managed care contract in July, and we added a Medicaid home visiting section. There wasn't really any verbiage in the contract specifically about Medicaid home visiting before. And so I think that we try to, with that, direct the attention to managed care of the value and the importance of this program to the state. So, and then one of the things that we're requiring of them is that the managed care organizations, that if they have the lab testing, which they do if it's done at a lab, they have the claims. If they have a positive pregnancy test, they should be contacting all pregnant members within 2 months of the positive pregnancy test and telling them about this program and offering the service. The other thing that I think was an important pivot and has really increased uptake is adding postpartum enrollment. At the beginning, we had nurse family partnership, which is required to be prenatal, but I think before 28 weeks. And parents as teachers can have postpartum enrollment, but the way we wrote our 1115 waiver only did prenatal. And it's just, we're in a very rural state. We have a significant shortage of resources. And sometimes we don't find that pregnant person while they're pregnant. And sometimes the first time they're asking for help is after a baby is delivered, and we had no model to offer to them. So although we all agree that the earlier the intervention starts, the better, we wanted to allow the intervention to start postpartum if it didn't start earlier. So we added parents as teachers postpartum, and then with the new models, there's several that are also postpartum. And then the other thing we did is we've been working with the providers. We meet with them, all kinds of meetings with the providers. We meet with ECD, we have office hours with the providers, been really trying to be accessible. And then we created a billing manual for Medicaid home visiting as well. And that kind of walks the providers through the steps of enrollment and billing and the guidelines. And then the other thing is just to be working with the partners and the other departments, if you're working with other departments. And so ECD, there was quite a large percentage of people getting Medicaid, getting home visiting on Medicaid, not through Medicaid home visiting. So really starting to require that if there is Medicaid funding, that is the first avenue for Medicaid home visiting before going to other sources. And I think that's it.
Great, thank you. And quickly before we transition to Oregon, I wanted to call attention that because of the high number of attendance we have decided to open up the Q&A so folks can start putting in some questions now, just so folks on our team can start to look through those. But with that being said, I'll pass it off to our folks with Oregon.
Thank you so much, Nina. Hello, everyone. I'm Kate Wilcox. I use she, her pronouns, and I'm the Maternal and Child Health Section Manager and our Title V Director in Oregon. And my colleague, Pamela Ferguson, will introduce herself when she gets to that portion of our presentation. Hi, Pamela. Do you want to introduce yourself now? Go for it.
Sure. Hi, everyone. Pamela Ferguson. I also use she, her pronouns, and I am the Home Visiting Systems Manager here at OHA Public Health Division. It's great to be here today.
So my great thanks to our colleagues in New Mexico and Alabama, because I think you teed us up that we can now take what you all have shared and take it down into the how-to level. As one little disclaimer, we are not Medicaid, we are public health, but within the Oregon Health Authority, there are several divisions, and one of them is the Medicaid division and our public health division. So we work very closely together, and we find that being under one umbrella, the OHA, is really helpful in terms of enhancing our communication and our collaboration. And we very easily pick up the phone and talk to each other, and are very much working side by side. So it's a really nice relationship. I will say that, well, let's go to the next slide. Thanks. So we're going to share a little bit about Oregon's home visiting programs and the program authorities that we have around it. And then we'll move into our different revenue types and then share what a sample local budget would look like as you implement using Medicaid, vis-a-vis MIECHV and other funding sources, because as Kate led off with, there's a very clear and need to make sure that those funding sources complement, coordinate, but don't overlap in ways that are not allowed. So next slide, please. So let me give you a little bit of landscape of home visiting in Oregon. We have a lot of different, not a lot, we have about 15, 20 different home visiting programs that reside in different agencies and sectors within the state. So in terms of our MIECHV program, our MIECHV program funds 3 evidence-based models. It funds and supports Nurse-Family Partnership, which we'll be talking about here. It also supports the Healthy Families America, we call it Healthy Families Oregon model, which is in our Division for Early Learning and Care. And then it also supports the Early Head Start home-based programs. So of those 3, Nurse-Family Partnership is the only one where we're using Medicaid targeted case management. The others use a little bit of Medicaid administrative claiming to support their work. But here, if we look at just the nurse home visiting programs, similar to the prior 2 states, their presentations, we have a mixture of evidence-based models as well as some homegrown. So Nurse-Family Partnership you see in blue, and that starts 28 weeks gestation up through age 2. We have what we call our Babies First program, and that starts prenatally up through age 4. And this is one of our homegrown ones that is based on best practices and evidence-based practices, but it does not have the evidence-based model designation. We really appreciate this model because it is very flexible. And so when a family misses the eligibility for NFP, they can enroll in Babies First if we connect with them at that point. Then in the past few years, we've been trying to implement and are making some good headway, the Family Connects model, which was already talked about in New Mexico. We are trying to roll this out statewide. We're about 1/3 of our state is offering this service, but it's a touch point that's about 3 weeks postpartum after the babe and the caregiver get home. It's just a brief touch point, and then referrals happen into other services and including home visiting programs as the families want and need. And then Cocoon is birth through 20 years of age, and this is for children who have a diagnosis. So it's care coordination for children and youth with special health care needs. And so that does go up to age 20. Very few families go that far, but it adds in that. So all 4 of these models are supported through targeted case management. We'll get into the details about that a little bit. We also have a pretty robust managed care program in Oregon called the Coordinated Care Organizations. All of this is a carve out from that. So we have a separate state plan amendment that governs the nurse home visiting programs. We bill by encounter. We can bill for the babe, the infant, the child, and for the caregiver, as long as those activities are meet the letter of the state plan amendment within that. So I think that's all I want to share on that slide. Next slide, please. So here's just a map of Oregon, kinds of shows these 4 different models that we have, and where their coverage is. Where it seems like there's a lot sort of on the left side of the state. That's what we call the I-5 corridor that goes up and down the state. It's where a lot of the population base is. The farther in the center and the eastern part of the state, it's very rural and frontier, and so not as many folks. But we are working on the green map, the Family Connects Oregon, to actually having statewide coverage for this. Next slide, please. Okay, so some of the authorities that we lean on in our section, in our part of public health, we have the Title V, the Maternal and Child Health Services Block Grant out of HRSA. And we also have the MIECHV program in our section. So those 2 HRSA investments and also have their own authorities about how we use the funding. In terms of our state general fund, we do get a little bit of state general fund for Babies First and Cocoon, which we, for the most part, send out to local health authorities. As a side note, the local health authorities are the ones actually providing the services. So these are public health nurses that are in the community providing these services. With the onset of the Family Connects Oregon program, we did get general fund and some additional Oregon revised statute and administrative rule authority to be able to use those dollars as well as implement the program. And then under CMS, and our Medicaid program, we have the Targeted Case Management Authority and Medicaid Administrative Claiming Authority. So those are the types of funding streams that we bring together to blend and braid to be able to make those programs whole, especially at the local level. So with that, I'm going to next slide and turn it over to Pamela, who she may be shy about saying this, but I am so happy that we got her at the state level because she comes from a local health department. So she has hands-on experience about what this blending and braiding is like at the local level. So Pamela, to you.
Thanks, Kate. And good afternoon, everyone. It's great to be here today to share a little bit about our multiple sources of revenue and how our programs are funded. And just looking at this slide, you can see we do have many different sources, and it does make it a little more complicated, but I think we're lucky to have a program set up just like ours. So I'll start first with Title V. As many of you know, that provides funding to our local agencies. We send down about 33% of what we bring in annually from the feds. So we get about 6 million. So about 2 million of that goes down locally for service providers. It also helps support workforce training and capacity building, which we feel is very important. We also have Medicaid targeted case management, and that is our largest funding stream for our local programs. And it also supports case management services and nursing assessments that are done during visits. And this is an important point. Currently, each encounter, so every time a nurse goes out on a visit, is billed out at $460 per encounter. So just to give you an example, one nurse home visitor billing out 30 encounters in a month. And if you think of a month, there's about 20 to 22 work days in a month. So that's definitely doable. And I've seen it at the local level. So that nurse could earn $13,800 in a month, which is about $165,000 annually. So you can see how that could build up a nurse home visiting program quite nicely. There is a local match requirement though, and it's 40%. So that means the programs are only earning 60 cents on every dollar. And that is a burden, and it's a burden that we continue to hear about from our local partners. We also have Medicaid MAC. Some of you may be familiar with this, but it's called Medicaid Administrative Claiming, and it is another great source of revenue for our programs. And it's an opportunity. I always like to say that when we try to get people to participate, but every quarter programs need to do a time study, and in order to draw down federal dollars that are available, and it's for non-billable work that supports that workforce. And there is a match requirement, of course, and it's 50%. And right now, not all of our programs across the state are participating, but we are encouraging them to do so because it does bring in a large amount of revenue. We have a coordinator who works with the local sites, and he's been going out, basically doing a roadshow and providing training for them if they want to participate. And we would like to get all of our sites into this program. We also have, as Kate mentioned, MIECHV grant funding. And in Oregon, we provide funding to 12 Healthy Families Oregon programs, 7 Early Start home-based programs, and currently 5 of our 9 nurse family partnership programs. And this funding helps to offset salary and training costs. We also, I think as Kate mentioned, we have state general funds, fairly limited, I would say, with the exception of our Family Connects and Nurse Family Partnership programs. And you heard through legislation, we now are able to pay that local match through our state funds for those 2 programs. And we continue to advocate for more funding for our other nurse home visiting programs, specifically Babies First. And then finally, there are always opportunities at the local level and regional level sometimes for tapping into care coordination organization global budgets. And that's been happening lately, and it's great for us to see this. Although it's a relatively new revenue stream for a lot of counties, but we're out there listening and trying to support that. And one I just want to bring up, in Central Oregon, there is a program called the Central Oregon Perinatal Care. And it started first with a very small amount of local funding, about $20,000. They then applied for a regional grant, and that grant was, it became almost reoccurring for about 8 years. And I just heard from one of my colleagues in Central Oregon that they now are going to receive a CCO carve-out, which will allow them to pay for community health workers. And you think about that, we're always looking at our nurse home visiting capacity and workforce. If you bring in community health workers, it expands that capacity because they work together and they're able to go out and do home visits as well. So we're really excited about programs like that, and we'd love to see more of them over time. And now I'm going to show you, because I think it's important for everyone to see what, it's complicated, but what does it really look like at the local level to fund a nurse home visiting program? So this is a medium, I would say medium to large nurse home visiting program. It's high level, it's a projected budget. So the actuals, if this was a real budget, every month you would see the actuals hitting against revenue and expenses, and that would be tracked very tightly month to month. And a budget like this typically exists within a bigger section. So there might be a WIC program and a reproductive health program and a vital records program, and it might be a $6 million program budget. But this is just looking at what would it cost to run a nurse home visiting program. So starting with revenue, first you've got, I mentioned Medicaid TCM billing. That's the majority of the revenue that we're going to see in a lot of local sites. So $750K, I believe, is a reasonable number. Medicaid MAC, I've seen it bring in up to $400,000 in federal funds over the course of 1 year. Local general fund is highly dependent on the support you may be receiving from your local commissioners, because that comes out of county budgets. And I'm estimating 170K here. MIECHV contract, again, those are just our nurse home visiting programs that are nurse family partnership. Those 5, those will have contracts with the state for a certain amount of money. I'm estimating about 200 here. And then CCO carve out, again, that's not happening across the state, but it's starting to happen. And it's in a positive way. And then state grants, again, that's going to bring in a little bit of money for all the programs, but it's money that they need to do this great work. And then you'll see down in expenses, you can see what the primary cost is, and that's staffing, it's personnel. So estimating over $1 million for staffing, including the overhead fringe, and then a little bit of materials and services, and then that local match that I mentioned, that has to be built into the budget in order to draw down those federal dollars. So that's just a quick snapshot of what a local budget might look like in a medium-sized county. And with that, I'm going to turn it back over to Nina. Thank you so much for your time.
Great, thank you so much. I'm going to stop sharing my screen and quickly pass it off to my colleague, Kate, before we get into our Q&A.
Thanks, Nina. I just realized that I was remiss in not actually referring you all to the fact that long before my time, but not before my HRSA colleagues' time, in 2016, there was actually a bulletin that was put out by HRSA and CMS together that has a lot of information about funding, about MIECHV funding, that sort of talks about some of the strategies that the states that presented today have taken up. So I think I can drop something in the chat and folks will see it. But I can also just direct you to the fact that it's a 2016 informational bulletin on this topic, and you should be able to find it. So just so that, oh, thank you.
Yeah,
someone was able to drop it. So because I think that's a really foundational document, and it has a lot of information that states that are interested in taking this up or thinking about it would find helpful. So with that, I think Nina is going to, I will say the following. I don't think we will probably get to all of the questions in the Q&A because people are asking a lot of really wonderful questions. Don't stop them from coming. So please keep them coming, and we will figure out if there's more information that needs to be put out related to the questions. And there's more information that we can share, or if we need to have some sort of follow-up, we can do that as well. So appreciate the level of engagement. And Nina, I will turn it back to you.
Great. Yeah, we just wanted to, again, give a huge thank you to our state colleagues for walking us through these models. So we're going to just start kind of going through some of the questions that are being tossed in the chat. Starting with this is for the states. With staffing shortages, is anyone utilizing community health workers within their home visiting models? If so, how are you utilizing them?
This is
Yeah,
Pamela again from Oregon. As I just mentioned, we're seeing that a lot more. I mentioned in Central Oregon, but it's also happening in Clackamas County and many other counties. So yes, we have a program where we can certify community health workers across the state, which allows them to then build targeted case management. So again, that helps to build that workforce at the local level. So it's a partnership between the nurse home visitor and the community health worker. And the nurse does the assessment and then can work in partnership with a community health worker. It also brings in people that are from the community. So we think it's a great program. So yes, we are advocating for that.
Great. Did any other state want to share before we move on?
So we don't use community health workers in our home visiting program. We have a little bit, there's kind of some overlapping programs that might eventually link up better. So we just started reimbursing for CHWs in June. So they can reimburse as community-based organizations or as individuals or as part of clinics under a standing order. And so they're kind of just getting going on figuring out how to do that. And there is going to be a perinatal CHW certification in the state. So I see that. Someone muted me. Do you want me to keep going?
Sorry.
Okay. All right. Yeah, so I think that there's some potential for that later. And then the other place that we've been using community health workers is that in our new contract, we have a pretty robust care coordination program within our managed care. And we're mandating that care coordination for perinatal members be delegated to community-based organizations. So the MCOs have to give their administrative funding to community-based organizations to do care coordination. And that's also largely CHWs. So we're kind of coming at things from a bunch of different angles. They haven't met up yet, but that would be a good goal eventually.
Great, thank you. And this question actually is specifically for New Mexico. What has happened to home visiting programs with the requirement to be Medicaid? Are they willing/able to make that shift?
Well, that just changed. They have at least a year to make the change. So it's mostly the ones that are coming on are getting that socialization. I wouldn't say that anyone's getting, their funding turned off tomorrow. There's just kind of this communication that they need to start pivoting that direction. There is a lot of nerves. This is an area, this is a challenge in our state for sure, because we have significant interest from the administration in doing home visiting and from the legislature. And we are brought every 4 months or so to say why we don't have more people in the state in home visiting. And we had this report that showed that only 6% of home visiting was paid for by Medicaid. And that is a kind of a piece of data that keeps coming up again and again. And so there's a lot of pressure to move that funding from over to Medicaid. And so, but I think it's a challenge. It's a challenge for them for sure. So we're trying to just provide the technical assistance, but the push to go that direction is kind of coming from above us.
Thank you. And moving on to a few questions for Alabama. Does your targeted case management program cover all of the aspects of NFP, or did NFP change their model to match the targeted case management benefit?
That's a great question. That's currently what we're working on now, and one of the things that we found in our most recent audit. But currently, NSO did not adjust their model. And right now we're trying to align our model to fit with theirs. So the answer is no.
Okay. And just following up, what is the rate that you have for it, and how did you build that, or what is that based upon?
We work with our actuary to come up with that rate, but it's $765 and some odd cents.
Great, thank you. Okay, we're gonna give a little break to the states and ask a few questions for the folks at CMCS and HRSA. The first one being, if we're thinking about how best to do this in our state, what's the best way for us to get more help or technical assistance?
I think that one's for me. And what I would say is that depending on what authority you're thinking about using, your state probably has existing contacts for each of those avenues. So if you're seeking an 1115 waiver, or if it's something within state plan authority, your state has existing contacts for each of those approaches. And what I would encourage is to get in touch with CMS and let us know what you're thinking about. We will do as much as we can to support, as including as you're thinking about developing something, because we have some experience with other states that may have, for instance, I'll just use targeted case management as an example, taken an approach to targeted case management. I think folks would be able to help you here and would be excited to hear about your taking that on. And I'm sure the same goes with the state demonstration groups around 1115 demonstration projects.
Thanks, Kate. Another question directed more towards you and HRSA, is that my understanding is that MIECHV requires states to concentrate program funding on low-income children and includes limits on admin funding. Given this, and states like New Mexico requiring all home visiting providers to bill Medicaid first, is there a possibility that states could risk underutilizing MIECHV if they mandated all providers access Medicaid funding? Would that be something to consider looking into federally to ensure MIECHV can help with systems connections if direct program funding is taken care of?
Yeah, I can take that question. Thanks. MIECHV requires state awardees to prioritize services to certain priority populations, including low-income families, as you mentioned. The MIECHV statute also requires awardees to budget no more than 10% for administrative costs, with certain exceptions. In terms of the last part of the question, so with the MIECHV program, at least 75% of the funding needs to be spent on service delivery. That does leave a remaining 25% of the funding that could be used for systems coordination activities. So I do want to emphasize that there is some flexibility in that amount of funding. And this is really what you raise is what states are grappling with, is how to braid MIECHV and Medicaid funding. So thanks for the question.
Thanks, Cindy. Moving back towards the states for some bigger open questions. Sorry, let me find, I lost my place. Okay, do your states have competition between the various home visiting models? It seems there are internal fights in my state about which model should be expanded if we expand. We don't do Medicaid home visiting reimbursement, and I don't believe we are getting 3-to-1 MIECHV match.
I'll take a first try at this one. Yeah, there is inherently competition. And what we're trying to reframe with a lot of work we're doing using MIECHV dollars for systems work within that allowable percentage is really showing how the collective capacity we have as a home visiting system is far less than the need that's out there. And so the competition really doesn't get us anywhere. I will say that the competition comes a little bit more when it comes to the legislature and gaining additional state general fund. Our non-nurse home visiting programs are primarily funded using state general fund, or like early Head Start, home base, sometimes there's some federal dollars, but that's where the MIECHV dollars come in and really help support those programs. Whereas the NFP portion of our MIECHV program is able to garner, we got some additional different state general fund to provide the Medicaid match so that they have a more steady funding stream in the billing of targeted case management. So trying to say it doesn't matter, we're all in this together and trying to figure out what funding stream works best for which model. We have encouraged over the years the Healthy Families program to try to work with Medicaid to get a state plan amendment so they could also tap into Medicaid, but to date, it hasn't happened yet, but that's an area of growth that we could probably look at.
Just want to respond to about the matching, the 3-to-1 MIECHV match. And I see that you're from Arizona, and yes, Arizona did request and receive the MIECHV matching funds. I would ask you to coordinate with the Arizona Department of Health Services for some additional information on how they're planning to use that match funding.
Thanks. And one specific question for Oregon is just quickly, could you share again the required match for targeted case management and for MAC?
Yeah, and this is actually set by CMS. So I don't know, maybe Kate, you can check my math here on this, but it also depends on who you're putting the claim against. Like, is it the child? Do they have CHIP insurance? But in general, it's about $40 of non-federal put up to draw down 60% to make the claim whole. And then for Medicaid administrative claiming, it's a 50-50. So 50% up, and then you could draw down the other 50% from the feds.
So I'm going to say the following. First of all, I always defer to my financial management group colleagues around anything related to claiming. The first number is going to be state dependent because it depends on what your admin rate is, whereas administrative claiming is the same across the country, that it's 50-50 match. So if you are interested in knowing and talking more about that, I'm sure folks in FMG would be willing. I know states have contacts within the financial management group to have that conversation.
Great. And while we're kind of getting more into the nitty-gritty, just one more specific question coming from Maine. Someone says, I've been working in the reservation, providing home health services for acute and case management care needs. We initiated this service as we're rural, and our service area in Washington County does not have enough providers for the service needs. Would you be able to offer me some guidance for billing?
I would say from the CMS perspective, I would phone a friend on that one. We will, but we can take your contact information because that sounds like it's a very specific information there, a very specific question. And also there may be specifics related to the fact that their service is being provided on the reservation, that also it's sort of a third potential funding stream and or agency, right? That I would want to make sure that I had the proper information. I don't know, Cindy, if you have any information specific to providing these services on a reservation, but we can definitely get your information and find the right people who can answer that question.
Yeah, we do. The Administration for Children and Families, who does oversee the tribal home visiting program, would be a good resource, and we can connect with them.
Great. Yeah. So if you want to put a way to reach us in the chat, we can definitely do that. And while I have Kate and Cindy, are there plans to update the joint bulletin?
What I would say is that this webinar was what we hope to be a first step in more engagement together. We've been working really closely, CMS and HRSA, on this issue and engaging and hearing from folks about kind of what are the outstanding questions that weren't answered in the 2016 bulletin. So I can't speak to specificity on updating that document. I think we're very interested in continuing to collaborate and providing as much sort of guidance to move this work forward because we think collaboratively, we think it's really important, and clearly there are some states that have really taken the bull by the horns and are utilizing the opportunities as much as possible, and we would love to see that spread. Cindy, I don't know if you have more to say on that.
Nope, perfect. Thanks, Kate.
Thanks. And then back to the states. Have there been efforts to do outreach for populations who aren't having touch points with the healthcare system? And if so, have any efforts been particularly effective? Since so many home visiting models require moms to be referred early in the pregnancy, we miss out on serving many families who need it most.
Well, I can talk a little bit about, well, I talked a little bit about it. It's a little early to tell if it's going to be effective yet. So we did have these new requirements in our new contracts that all Medicaid people with a positive pregnancy test get a call. I mean, as part of kind of care coordination, I get a call and a referral to Medicaid home visiting, or a recommendation, I mean, not a referral without consent, but a recommendation. And then we have this care coordination program where every pregnant member is kind of auto enrolled in care coordination. They can always opt out, and if they don't pick up the phone, then they opt out. But they're all contacted about care coordination within the managed care, so that we're hoping that that's a way to reach people who might not access the system as well. But I mean, it's definitely a challenge that we have them join later.
Great, thank you. Moving on, sorry. Okay. I'm curious about best practices for coordination across home-based programs available for children under 5. For example, early Head Start, early intervention services.
I'm not quite sure what the question.
thinking
Let
was
me try, yeah, let me
I
try
think
to
that was
expand on the
attached.
question.
Yeah.
So I think the question is, there are a lot of different programs in what I like to affectionately call the little kids space. Things like Head Start and home visiting and other programs, and how does maybe the home visiting is the home visitors are the locus of coordination, or there's other entities that are the locus of coordination, but how, like, is there what I would think of as sort of a system of care that's within your states where those entities are interacting with one another, or is the home visitors kind of their own thing? And then when kids, for instance, move into the early childhood education setting or other settings, do they then, like, is there good connectivity there?
Yeah, and we used to have some early childhood systems programs at HRSA that we fund. So maybe we can drop a couple resources in the chat. My colleague Dina Leeser will do that to provide some examples of some coordination across early childhood programs.
Great, thank you. And okay, so and this might be a question for both states and CMCS and HRSA, but can only county government conduct targeted case management, or can community-based organizations as well? So can CBOs conduct targeted case management themselves, or do they need to flow through the agency?
I'll start out and then I'll have states jump in as well, which is targeted case management does not have to be provided by the agency. And there are many different examples of targeted case management, which is a very specific Medicaid benefit. But any one state actually could have multiple targeted case management programs with multiple targets, meaning the young children could be the target, the pregnant and postpartum mom could be the target, a specific subset of kids could be the target. And often what you'll see is that depending on what the target group is within Medicaid, the state will have a group of providers who are appropriate for that. Often they're community-based organizations in my experience, but not always. So I will, maybe folks from the states, maybe each of the states, since I think you all use targeted case management, could talk, two of the three use targeted case management. Maybe Travis and Kate could actually say who are their targeted case management, who is actually providing the TCM. Kate, you want to go first?
Sure, I'm happy to go first. Yeah, we are one of those states that have multiple state plan amendments that have multiple targeted case management kind of foci depending on what needs to happen. So the only one that I'm engaged with is the nurse home visiting one. And the way the state plan amendment is written, it is nurses. So in our experience, and this may just be the way we're implementing it, is that we do use local public health. And part of it is just making sure that we get the match correctly done. But we do have like not-for-profits, community-based organizations that work with the local public health authorities to be able to do the billing correctly. So they might be providing the services. It may have to go, they are designated by the authority and then they could do the billing. So, but that's just the way we're implementing it. I think there's probably lots of other ways to do it.
Thanks, Kate. Travis, what about in Alabama?
In Alabama, we typically enroll our sister agency or other state agencies to render the TCM services. But for the exception of NFP, we do allow those NFP providers to enroll as a TCM provider.
Right. So any way you slice it, you have to be an enrolled Medicaid provider to provide TCM. So, and I know from what I didn't say at the top of the hour is I used to be at a state Medicaid agency. And I know that one of the questions that comes up is sort of for organizations that haven't been Medicaid providers previously, that can feel like a big leap to become a Medicaid provider and then do Medicaid billing. It sounds like from what Kate said, they have maybe a billing entity that helps with that to make sure that the billing happens correctly. Travis, from what you said, it sounds like in Alabama that the Nurse Family Partnership are enrolled, that those entities are enrolled providers. I think there are many ways to sort of help community-based organizations that maybe for other services are not Medicaid providers to become Medicaid providers and then help with, there was early on, we had a question about billing as well, right? So we know that can feel daunting to community-based organizations. And so I would encourage for state Medicaid agencies as well as the MIECHV program sort of working together to help identify where those worries, hurdles, et cetera, are, so that then the community-based organizations can both enroll and then bill and feel like they're doing all of those pieces correctly, I think is a good place to focus as you're getting started. So I'll turn it back over to Nina.
Thanks, Kate. I think we'll probably have time for just one more question before we wrap things up. And this is for Cindy. Is HRSA planning to release information on the states that made the match and how they made it? We're trying to get Governor to prioritize this in upcoming budgets, and it would be helpful to have this information on a public website.
Yeah, thanks for that question. So my colleague's going to drop into the chat the list of awards made to all of the states, and I am absolutely proud to say that 53 out of 56 states and jurisdictions have met the match, and you are correct in that Rhode Island did not apply for the entire match. I would encourage anybody who wants to know more about the match within their state to contact their MIECHV awardee. What I will say is this year, because the non-federal part of the match was relatively small, most states, if not all, met it through state general funding or state sources of funding. So I think with that, that's important, but we will talk internally about future years about how to communicate that information to others as well.
There was another question. I know you said it was going to be the last question, but there was another question about kind of convincing folks of the importance and value of this work. And I think there is a fair amount of literature and evidence on the long-term impact of intervening early with young families, especially young families at risk. So hopefully that all can be helpful. And it looks like some of those resources were already put into the chat. Because we know that sometimes you all are looking for those concrete examples of return on investment and why this is an important priority. So hopefully the resources that folks put in the chat are helpful.
Great, thank you, Kate. And so as we wrap up, I wanted to thank everyone for coming. We are collecting all of the questions from the Q&A chat, and we'll be sure to be looking them all over internally. We are also, this has been recorded and are hoping, I believe, to find a home for this somewhere online so folks can come back to it and look at the presentation. And with that, I just wanted to give one more big thank you to our states for really walking us through all of their different models. It's been extremely helpful, along with, all of our advocate organizations who've been encouraging this. We're really happy that we were able to get this going with such a large participation. Is there anything else any of my colleagues want to say?
No, just thank you so much it was wonderful to see this level of engagement, not just folks who are on, but so many questions that we couldn't get to them. So really appreciate it. Cindy, anything else?
Yes, just want to thank everybody. I'm so excited that there's so much interest in home visiting. We always love that. And I think it's a testament to the great work that you all do every day on both the Medicaid and the MIECHV home visiting side. So thank you.
Thank you so much, everyone.